Hello, everyone. Good morning, good afternoon. Thank you for joining us today. I can see some of you are already saying hello in the chat. Please feel free. Let us know, say hi to the group. Let us know where you are from. And we'll begin here in just a moment. There's several people joining. Let's just give it one more minute. Great. Okay, hello everyone again. My name is Lacey Ahern. I'm a program director at Global Partners in Care. Our mission is to enhance access to palliative care globally. And today we are really pleased to partner with PATCH South Africa to talk specifically about children's palliative care. Please, as you're joining, feel free to introduce yourself in the chat and say hello. Just a few housekeeping notes. You will see that this is not a webinar, in fact, but we are in a meeting format. And the reason for that is because we want to have a more interactive session and discussion with you at the end of the presentations. So we kindly ask that you remain muted during the presentation so as not to disturb them. And then when we come to the discussion section at the end, you'll be welcome to raise your hand, ask questions, and join the conversation. During the presentations, if you have any questions for any of our presenters, please feel free to put them in the chat, and we shall bring those up and address them accordingly. So with that, I'd like to turn it over to Cindy Searfoss, who is the Director of Partnerships for Global Partners in Care. Thank you.
Thank you, Lacey. Thank you, everyone, for attending today. We are so pleased to be able to join in learning about strengthening children's capacity in children's palliative care. What I'd like to do is just, for those of you who may not be familiar with Global Partners in Care, is provide a little bit of a background of who we are and what we're doing and our role in this engagement. Global Partners in Care was founded in 1999. This was following a visit by U.S. hospice providers to South Africa in response to the HIV/AIDS crisis. It stayed an independent, small, nonprofit organization in the U.S. Until the early 2000s, when it became part of the National Hospice and Palliative Care Association. Global Partners in Care then became an affiliate of Center for Hospice Care in 2017. We are located in northern Indiana, about an hour and a half drive east of Chicago. Center for Hospice Care has had its own partnership under Global Partners in Care with the Palliative Care Association of Uganda since 2008. As Lacey noted, our mission is to enhance access to palliative care around the world. And we do that particularly in low to middle resource settings. We also do this through our partnerships, which is twinning palliative care providers, particularly in sub-Saharan Africa, with US organizations, which are typically hospice organizations here. And then we also do this through education, through research and collaborations, like this collaboration with PATCHSA. Our partners range from home care providers to clinics to palliative care units within hospitals, all the way up to national associations like Center for Hospice Care's partnership with the Palliative Care Association of Uganda. And speaking of Uganda, if you're going to be at the 7th International African Palliative Care Conference in August, please look me up, please look Lacey up. We will be there for the pre-conference and the conference, and we would love the opportunity to meet with you and talk more about this webinar and any other palliative care topics in person. We also ask that you take a moment to visit the Global Partners in Care website, and we'll put that in the chat for you later, to learn a little bit more about our work, our collaborations, and what we're doing to enhance access to palliative care. It has truly been a pleasure to work with the PATCHSA team. Their approach to pediatric palliative care is inspiring. They truly are people who care for people who care, and we are delighted to have the chance to work with them on this webinar. I'd like to begin the introduction of the team that will be presenting today with some brief bios and overviews, and we'll start with Tracy Rollins. Tracy is a professional nurse, midwife, and educator, and she started her palliative care journey 12 years ago, offering palliative care services to her local rural community. In 2017, she completed her postgrad diploma in pediatric palliative medicine, and early in 2018, she joined PATCHSA. She is presently the education and training manager for PATCHSA, as well as part-time tutor marker for the UCT Pediatric Palliative Care Postgrad Diploma course, alongside Dr. Michelle Meering. Tracy will be leading off the program today with children's palliative care. What's the difference? And I think you'll find her presentation provides a clear, concise overview of the fundamental aspects of children's palliative care, which you'll see abbreviated CPC throughout this webinar, as well as its provision in South Africa. The next presenter will be Joan Marston. Joan is a professional nurse working in hospice and palliative care for 33 years as a clinician, educator, and advocate for children's palliative care. Joan established Sunflower Children's Hospice in 1998, which has been in a GPIC partnership with Vitas Corporate for 19 years. She was the first chair and CEO of the ICPCN and was a founding member and vice chair of PATCHSA. She is the vice president of the Elizabeth Kubler-Ross Foundation Global and is presently working to support CPC in humanitarian settings and crisis as an executive committee member of PATCHSA. Joan will be presenting Developing Models of Children's Palliative Care. She will discuss 3 models of developing a children's palliative care program, as well as the forces that influence the development of these models. Her wealth of knowledge about CPC and focus on keeping children at the heart of all we do is incredible. Sue Boucher will be our last presenter, and she will be presenting she is presently the program and communications manager at PATCH. She is an author and educator by profession and has been involved in the field of children's palliative care since 2008, when she was appointed the communications manager of the International Children's Palliative Care Network. Sue is a founding member of PATCHSA and has been working as an employee of the organization since November 2019. She will provide a detailed overview of Palliative Care for Children South Africa, the organization known as PATCHSA. She'll share her background, their background, history, as well as numerous ways that they offer support and resources for children's palliative care. Thank you everyone for joining us today again, and I'd like to invite Tracy to begin her presentation.
Sorry, I was not mute. Can you all hear me?
Yes, thank you.
Sorry, I just want to start my video as well. Okay. Thank you very much, Lacey and Cindy, for the introduction, and to Ethan, who's part of Global Partners, for the opportunity for this presentation. Today, I'm going to just give a sort of brief overview of what the differences between adult and children's palliative care and why these are so significant when you're thinking of programs and services that need to be offered to children. And then I will do a brief overview of the need for palliative care in South Africa and the services that are currently available and programs. Okay, so I just found this this saying from a psychologist, Roger Hart, and I think for me it just speaks volumes. That children are undoubtedly the most photographed and the least listened to members of society. And when we think of what is different about children and adults, often they say what they feel, they share what they want, but at the same time, do we really listen to what their needs are? And I think that is one big significant difference between adult and children's palliative care. So we need to remember that children are not small adults. They think and behave differently to the way adults do. And that goes through the developmental stages that we have to take into consideration from the time they're born until they reach their early adulthood. And then having a serious illness is not a normal condition for most children. And this offers unique challenges for professionals caring for children who are sick. They don't present with the same overviews with the illnesses and the way they're sick, and they may be more needy as they're so dependent on their parents and other adults or guardians to take care of them. And then often with their children being dependent, they are the ones who rely on their parents to make their decisions for them, especially younger children. They can't make their own decisions. And therefore, with this, adults have to be part and parcel of the care that is provided to children. In children's palliative care, we think of communication as one of the most important aspects of when we offer palliative care service, when we build that relationship. And then we've got to remember then with communication with children, we've got to think of their cognitive development, their physical development, the social aspects. They go, how do they communicate? At what age and stage are they cognitively? And we need to be speaking a language that is different to each and every one of these developmental ages and stages. Children are very often afraid of being separated from their family, friends, school, and home. They are real social beings and are part of a family. And if that is taken away from them, they are lost, they're anxious. And I often think in the South African context too, in our hospitals, children are considered adults from the age of 12 and are put into adult wards. And you can just imagine how frightening this is for a 12 or 13-year-old to be put in a ward of adults and not surrounded by their families. So we need to consider their needs when we are looking after them in various institutions and organizations. Then we also have to take the educational needs and the right to play into consideration. This is what children need more than anything, that social interaction, that educational need. And in the picture on, I think it would be, it's on my left, I'm not sure what you're seeing it on the screen. I'm here with a group of educators, and this is a patient cared for in our local community. His name was Nambi, and we like to share his story that he was diagnosed with a neuroblastoma, and after a year or so of treatment, it was decided that further sort of chemotherapy or treatment would be futile. He developed metastases, he was paralyzed, and he was in a wheelchair. And all he wanted to do after my first couple of visits, after spending time finding out what his needs were, was he wanted to go back to school. He'd missed a whole year of school, and he was just desperate to interact with his peers and see his friends and speak to his teachers. And his teacher is the lady on the right with the red duck on. And we organized for him to attend his first day back at school on a children's Hats On for Children's Palliative Care. This is in 2019. And we took him back to school. And he interacted. He didn't want to leave that day. His father had to go back and fetch him. And from that interaction, we realized he actually needed that continued stimulation. He was a bright boy who wanted to go further. His beliefs, his faith and beliefs were just one of those that he believed he was going to live, and he didn't want to get left behind. Anyway, to cut a long story short, we did manage to get him back to school. For that last few weeks of the school year, he wrote his exams and he passed. And his mum, one of the words she said to me after we had done it, she said she hadn't seen him happier for 2 years. But sadly, at the end of that year, actually on the 1st of January 2020, he passed away. So that was just a need fulfilled, and why it was so important that we look at that need and consider taking children's rights to play and education into consideration. And that's what makes it different. Okay, then the other things we've got to consider is the medications used, the doses and side effects that are encountered when treating children are different. They react differently. Symptoms can be difficult to assess. It can be a variety of symptoms, and especially in non-verbal children, our younger children, our infants. It's not often that we can just identify these symptoms. It's a lot of looking at body language, how they play, how they react. And so it takes an intense assessment, a sort of impeccable assessment to understand how they are suffering. Then with children, we don't just talk about cancers. There's such a different spectrum of diseases that we treat in children's palliative care. These syndromes, congenital conditions, metabolic and genetic conditions. And these can be there from birth and go through childhood into early adolescent and then into. So the length of illness can vary greatly from days to years. And therefore, our engagement in care may extend over many years, unlike adult palliative care, where it's often just a couple of years, months, or days. Then children's understanding of illness and death and dying is not the same of adults. And it goes hand in hand, that it aligns to their age and stage of development. And this includes a spiritual aspect as well, the social aspect that we have to consider. And it's important to understand how children grasp this understanding of the illness. And often we think children don't understand, but they're very wise, and especially a sick child, they really have a good grasp of their condition and learn very quickly. And we need to acknowledge that and share with them and think about truth telling and including them in decision making when we are working with them. The way parents and the family then grieve after the child has died will differ, but children are not meant to die before their parents. Siblings are affected immensely, and often they're the forgotten mourners. So we need to consider the whole family when we working with children in palliative care programs. And it's ongoing, and children themselves will have anticipatory grief when they are diagnosed as they get older with understanding their condition. And we have to work with that. And that's why it's so important to include professionals from a broad spectrum of a broader range of people who need to be involved in care. And we do know as adults, we often nervous, anxious to work with children. And I think most of us who are working in children's palliative care often get asked, well, how can you work in that? Isn't it depressing? Isn't it sad? And I think for most of us who have worked in this field, really sort of come to acknowledge the difference we can make and the need that there are people out there who understand children and are not treating them like adults. And I love this picture. This is the PATCHSA team. And you can see the diversity of the team. There's nurses, doctors, educators, social workers, art therapists, play therapists in this team, to name a few. I'm sure if you go and look at the website, you'll be able to see their team. Okay, so what is the need for children's palliative care in South Africa? So there's an estimated 1 million children who need palliative care. And sadly, with only less than 5% accessing these services, which are a drop in the ocean. In a study done back in the middle, between 2012 and 2015, this was the need for palliative care. As we can say, things have definitely changed because the study was done quite a few years ago. We can see that over 300,000 children were needing specialist palliative care. And very, very sadly, only about 14,500 children were receiving palliative care. And if we look at that 14,000 and we see there's an estimated million children needing palliative care, it really is a drop in the ocean of the children receiving palliative care. So then why are so few children who need palliative care not receiving it? Is the concept of palliative care poorly understood? Are there other reasons? Some of the reasons that we can consider, and there are many more than this, and I think it's good. I think what we're doing now and with networking, with global partners, with other organizations, is we actually identifying the reasons that it's so fragmented, palliative care service, why there's so few. And I think with identifying all these reasons and ones that we can focus on, there's definitely going to be a trend to moving forward in developing and more palliative care programs and services for children. So some of these reasons are that care is often fragmented and uncoordinated. Referrals are bad. There's often no referrals. In South Africa, our rural area, we sort of such a diverse population spread over a lot of ground there. The resources are poor in a lot of the rural areas, and often there is not that referral process in place. And then this leads to care being fragmented. And often most hospitals, there's actually no palliative care teams, especially those pediatric palliative care teams. There might be one or two who have got a bit of experience in palliative care, but generally they're very few and far between teams that offer specialist palliative care in South Africa. Again, we know professionals tend to lean towards curative treatment. We don't want to think that a child may die and rather try and cure them. And that would include that many for parents too. They would want everything be done for their child and then would not seek palliative care. Often treatment and care is disease focused rather than being family and patient centered. There are many, many myths or misconceptions about palliative care, and I think most of us working in the field do know many of these, but it's taking a long time to dispel a lot of these myths. And then also there's just a lack of under or postgrad education in children's palliative care. There is work being done to improve that, but and which is slow. But we're trying to get there. So then what palliative care provision can we find in South Africa? Currently, there are 5 recognized palliative care programs across the country. And these are children's palliative care programs, with 3 offering an inpatient unit, and which is usually for long-term care. In South Africa, most care is provided in hospital, in a clinic, or in a child's home, or a combination of all. Often it's the NGOs that are doing home visits, not specific palliative care NGOs, but just your normal home care services. And again, there's not that much referral to facilities, as they are lacking. Although adult palliative care services are available across South Africa, these services do not always meet the needs of children, as these care needs are often quite different to those of adults. And then again, negligible funding and resources are provided by our National Department of Health. Most of the funding comes from donors across South Africa, and all our pediatric palliative care programs spend a lot of their time doing fundraising, looking for funds just to maintain and sustain their organizations. Okay, so let's have a look at some of the organizations that are currently offering children's palliative care services. I mentioned PATCHSA, and that's found in Cape Town in the Western Cape province. They've got a diverse team, which I spoke about earlier in a previous slide. Then we have Sunflower Children's Home, and we are so fortunate to have Joan here today, who's going to share information about what and how Sunflower Children's Hospice came about and what their programs entail. Sorry. We then have Mduduzi Hospice Care for Children. That's a children's palliative care organization that is based in Durban, and it's run by Dr. Julia Ambler and Tracy Brand, a social worker. And they offer services in hospitals around Durban and include home visits. They unfortunately do not have their own inpatient unit, but it is on their wish list, as would be most of the pediatric palliative care centers that offer palliative care. We then have Lambano in Johannesburg. They have an inpatient unit, and they are the only pediatric palliative care organization that in the Gauteng and Mpumalanga Northwest area, which you can see there. So it's a big area that needs palliative care. Then last but not least, our latest or the newest palliative care home was opened this month, and it's called Butterfly Palliative Home by a husband and doctor team, Taryn Bell and her husband, and they've just opened with lots of wonderful pictures coming through on social media. So I would encourage everybody just to go and sort of do a web search on all of these different places that offer palliative care, and see what they do, who their teams are, and the services they provide. And just last but not least, I've just have a picture. This is the new Butterfly home that was opened, and just look how beautiful that is. Okay, any questions? Any answers? Thank you. Sorry, my last slide didn't come up.
Thank you so much, Tracy. That was a really outstanding overview to get us started. And it struck me just that the slide you showed about with the stats, the need of palliative care, and then the specialized need of palliative care. There's actually quite a lot that basic training in children's palliative care can provide in that big red circle you showed. So I think that's an exciting thing for us to think about, in the capacity building and strengthening of our children's palliative care teams. So I'm actually going to transition us straight to our next presenter. I don't see any burning questions in the chat. So Joan, let me welcome you to the screen, and I'm going to share your presentation here.
Thank you so much, Lacey, and thank you, Cindy and Ethan, for the help as well. And it's really good to be here today to talk about how Sunflower Children's Hospice has grown from the first early days until what it is now. And when I was asked to speak about models, it was really interesting when I followed the story of Sunflower across, in fact, more than 24 years, how the model has changed and adapted to the circumstances. So we started, could I have the next slide? Thank you. We started as part of Bloemfontein Hospice, the original Bloemfontein Hospice, which had started in 1989. And when I joined, it was a very traditional type of English style hospice. So our patients were mainly white people with cancer, and we started getting a few children referred to us with mainly genetic conditions. So our first children had spinal muscular atrophy. We had a little girl and later her brother, and many other genetic conditions as well. And at that time, I mean, there was really no palliative care training, let alone pediatric palliative care training in South Africa. So it was very much a case of learning on the job. And really, what did we know? And now these days, people would say, well, you need a children's program, you need a children's hospice, an adult hospice. But those, we didn't have Google, and we weren't as connected as we are today. And so it was very much a matter of learning from the children who came to us. And so those first few children taught us so much. But then came the influences, and the main influence in the development of Sunflower Children's Hospice as a separate, unique children's hospice came about because of AIDS. So in the beginning, we saw the usual picture. It was white gay men in the beginning, and then we started seeing others. Sorry, could we go back, Lacey, please? And then we started seeing the children. But when we started seeing the children, and as I say, we were scrabbling to actually learn and to develop our own training programs and to work out how to care for these children. And they were cared for very much within a family. And when the parents were sick or dying, it was the grandmothers looking after them. And so while we were looking after these children, we were looking after families as well. So being part of a general hospice was actually ideal in the beginning. And it was within the framework of the mission and the ethos of Bloemfontein Hospice. We decided early on we were going to take all patients who needed hospice care. It didn't matter what they had and where they came from. And so in the beginning, we were one of the very few hospices that actually took people with AIDS on as hospice patients. So it was in that mission and ethos that we were taking in these children. But the other thing that was absolutely crucial and key to our development was that because there were so few services, we very early on developed good relationships with the Free State government. And I say government because we had the Premier who was interested in what we were doing. We had Department of Health, Social Development, and Education. At that time, we had a really good champion for palliative care at national level, Cornelius Labello, and Michelle, you will remember him. But within the Free State Department of Health, we had all these senior people who really got palliative care, and they became our champions. We also had a really good relationships with other NGOs, the Cancer Association, and there weren't that many NGOs at that time, and of course the faith-based organizations. So we had really strong support from the Anglican Church, Cathedral, but other churches as well. So we came from this foundation of a strong ethos of taking in everybody, good relationships, and support from our community. So next slide, please, Lacey. And so our first model was really as part of this mainly adult focused hospice. And from 1990, we'd started seeing these patients. So before we started the children's program, this was a very integrated, mixed our daycares with children and adults together. Our home care, we were, as I say, we were learning as we went along. And we developed our own training courses, which later on were used by, became actually the basis of a lot of the training modules that we developed at national and international level. The next slide, please. And what was it about HIV and AIDS? Of course, we had a very high mortality. And we need to remember, it wasn't just our patients. We lost a number of staff members to AIDS as well. We didn't have antiretrovirals. And so when you got HIV, it was a process. We had infected mothers and children. The picture on the left is actually one of our staff members, Emily, who died of AIDS, with one of our babies who died of AIDS. And you can see the picture, the typical picture. And of course, we were seeing these funerals, this mass bereavement, a lot of grief, and just huge numbers of funerals every week. The next slide, please. So our model number 2 was we decided we needed to have a team that looked specifically after children. And we also realized, because parents were dying, the grandmothers were battling, that many of these children were dying in appalling circumstances. And so we needed a place to care for them. And like all hospices, we didn't have much money. And again, I mean, a real blessing. And Elizabeth Kubler-Ross always said there's nothing that happens without a purpose, is the head of health for the Free State was a pediatrician. And the medical director at the time and I went to him and we laid out our story. And honestly, at the back of my head, I thought he was going to say, that's a wonderful idea. Here, I'll give you a personal check, but we can't help you. But immediately he said, I'm going to put a team together and we're going to find you somewhere where you can look after these children, which was amazing. And we had this team of top people from the Free State Department of Health. And we went from building to building. The first place they wanted to give us was the old nurses' home at Pelinomi, which was the size of a hospital. So we said, no, we can't do that. And then eventually we found this little house in the grounds of National Hospital that became Sunflower House. And because there were so many children who needed care, and at that time, because of AIDS, there was a lot of money available. And it sounds, well, we're all scratching now. At that time, they were throwing money at us. And we had 6 daycare centers in a wide radius of Bloemfontein, that we had the shared governance, shared management and finances and fundraising. So it was one big organization, but with St. Nicholas Children's Hospice, St. Nicholas, Santa Claus, the bringer of gifts to children. We couldn't give them the gift of long life, but we could give them the gift of quality of life. And while we've changed our name now, the trust is still in the name of St. Nicholas, the giver of gifts. Next slide, please. And so we opened Sunflower House, as I said, in the grounds of National Hospital. And in the beginning, we had to look after adults in the house as well as children. And the wall of sunflowers that you see is very early on. The older children were saying to us, our parents have died. Who's going to remember us? And so we painted this wall of sunflowers and we promised them we would never forget them. And so when a child dies, their name is put into a sunflower and we hold a special service every year to remember these children, our special sunflower children. And it was put into the same area as the playground because we wanted everyone to realize that life and death are all part of the one circle and that they're interconnected. And that when people die, they don't leave us. They remain in our hearts and in our lives. Next slide, please. And so having this, and this is what I would say to so many, and if you want to start a children's hospice, either do it in a hospital grounds or near a hospital, because what we have now is we have this wonderful partnership. We're in the hospital grounds. We've had support from the medical directors, from the CEOs from the beginning, and the management. Our medical care comes through the Department of Family Medicine, and Professor Hanneke Brits has been our volunteer medical director for the past 20 years, has been an amazing supporter. We have a 24-hour pediatric clinic within 2 minutes of Sunflower House and A&E, and we have all the clinic services. We are linked to all the other departments, pediatrics, pediatric oncology, whatever our children need, they can be referred there. We have strong links with the pharmacy, who are really helpful. We have the hospital security, which I won't say much about that, but then we also have all the therapies. And almost every day we have occupational therapists who come, nutritionists, physios. The major maintenance is carried by the hospital, the incineration of all our waste, and we have a very involved dental clinic, because often these children have dental problems that are ignored because they are too sick to take to the dentist. So right next to us, we have a dental clinic. So you can see we're in this lovely network of services that we don't pay for. So it makes it a very cost-effective model as well. Next slide, please. And then model 3 was when we become strong enough to be an independent hospice. I'm still not 100% sure that was the best step, but it's gone well. So we had a separation of the adult and the children's hospices, and we still had all these different programs that we were providing, that we still provide. And then we actually raised 20 million Rand from USAID to do a 2-year project to develop and support and train in children's palliative care across the Free State with all hospices, and that involved Department of Health and Social Development and HPCA as well. And then for the past 24 years of the existence of this children's hospice, we've had ongoing local, national, and international supporters that have helped to keep us going. Next slide, please. We have a special program for the children in Sunflower House, because many of these children, they have advanced disease, they're severe disabilities, and it's a really beautiful program that even the most disabled child can be stimulated. So together with our occupational therapists, we have this lovely program within Sunflower House. Next slide, please. And then, of course, the community care services, and again, strong links with the Department of Social Development. And so we get a grant that helps towards funding our community care workers. And really excitedly, about a month ago, for the first time, we got a specific grant for the children in Sunflower House. And while it doesn't cover anywhere near everything that we need, it really does help us now to continue to provide our service. And then we work very closely with the social development social workers who assist us with many different aspects of social care. We do extensive training of community members. And just this past 3 weeks, our community coordinator has been training young men on the correct way to handle women, which I think, and she's an amazing teacher. And we do this training. We have 2 prisons that we're linked to, and we're training inmates so that when they go out, they know how to provide care for their own children as well. And then we have an amazing community poetry group where our adolescents, and we find that this has been the most successful group. We've had craft groups, we've had support groups, but the poetry group, where they are able to express themselves through poetry, through expression, has been an amazingly successful supportive group. And one of the poems has just recently been put to music for a big international project that is going to come off later in the year. Next slide, please. And then, of course, the ongoing community support. The community of Bloemfontein, who so often provide, especially with things like food and clothing and toys, and some funding as well. and our international community who have supported us. And here you see Sister Frances Dominica, who opened Helen House, the world's first children's hospice house, who is our patron, and Marie, a wonderful friend from the US, who has helped us over many years. So next slide, please. And then, of course, for 20 years ago, we had our first contact with what was then PATCHSA and is now Global Partners in Care. And we've had this wonderful relationship with Vitas. And there in the middle, you can see one of the groups that I met with in Miami. And we have a lovely trust, an active trust in the United Kingdom with such dedicated trustees. And every year they hold a project, Tall Flowers for Short Lives. And the person who grows the tallest sunflower gets a ridiculously small trophy, and that the people who grow these sunflowers are incredibly competitive. Next slide, please. So if I would say what was key to our sustainability, I think first the ability to adapt, to not remain as we were, to change as circumstances change. Then to continue to provide a good service and an ethical service, a service that people can trust. We have wonderful staff and volunteers. I have volunteers who were there the day we started this children's hospice, and that was before we opened the independent children's hospice. We have committed staff. If I tell you that half of the staff of Sunflower House and our community coordinator were there the day that we opened our program, and those we've only lost because they've retired or sadly in the AIDS epidemic that they died. We've worked on maintaining our foundation of relationships with government departments because we recognize universal health coverage has got to have palliative care as part of it. And also in maintaining these champions, these people who see what we do and who support us. And so it's really an integrated program, integrating with the hospital, integrating with community, integrating at government level as well. But also we've tried to give, so we gave back through the Barnapili project, which was that 20 million rand project for the province. But we also, before that, raised fundings from Bristol Myers Squibb to train trainers in home-based care, again for the whole province as well. So we try to give back. We share, when we have excess food, we share that with other programs. We have baby clothes that we share with the hospital. And so we try to give back to our community, which gives to us, again, with student placements from school, students who have to do community service, to students from the University of the Free State and Central University of Technology as well. So next slide, please. And we started off with the Methodist Church. We went to the Anglican Church. We have support from all the different faith groups in Bloemfontein. But as you know, we all struggle financially. And so we always say every month a miracle. And we've been honestly so blessed with our chaplains from the beginning. Father Keith, then Father Joshua, and now Father Lazarus, who's the Dean of Bloemfontein. And they all have the most amazing connection with children, absolute naturals, and children talk to them. Children tell them when they're going to die. Children call them when they're dying. So this has been one of our great successes as well as our chaplaincy program. So next slide, please. And then, of course, I think the main thing is we keep children at the heart of all we do. So everything we do, we say, is this going to make a difference to the children that we care for? And if it doesn't, then we question whether it's part of our program. But if it does, then we try and integrate it into the program as well. And so these children, while they've given us a lot of heartache with their deaths, they've also given us a huge amount of joy. And we're just so grateful that we've had this journey together with them. And next year we celebrate our silver anniversary, which is really quite an achievement. And who knows, if we go to the next slide, the question is will there be a Model 4? I'm pretty sure there will, because we need to be even further integrated into the health services if we are going to be sustainable into the future. So thank you.
Joan, thank you so much for sharing that story. What an incredible start for Sunflower, for St. Nicholas Children's Hospice, to where you are today. It's just, it's wonderful and inspiring. Thank you so much for sharing that. Okay, I'm going to once again take us right next to our next presenter, and then we'll come back for discussion after that. But I'd like to turn it over now to you, Sue. Thank you.
Hi, everyone. Can you see my screen, Lacey? Can you just tell me?
Yeah, go ahead and hit the screen sharing at the bottom, the full screen. So we, yep, there you go. Thank you.
All good.
Yes.
Thank you so much, everybody, for first of all joining the webinar. Huge thank you to Lacey, Cindy, and Ethan from Global Partners in Care for organizing this. And we're really looking forward to sharing the resources that PATCHSA has with you. And we really hope that it will encourage you to become more involved with the work that we do. So what is PATCHSA? It stands for Palliative Care for Children South Africa. We're a national network of organizations and individuals who work or have an interest in the field of children's palliative care. The aim of the organization is to ensure the right of every child to access quality palliative care in South Africa. The organization supports and serves 3 often overlapping groups of people, these being the general community, so information, advocacy, trying to make sure people understand, as Tracy spoke about, the myths that there are about palliative care, particularly children's palliative care. We also have, we help and support family members. They are the people that really are suffering the most when it comes to children's palliative care, and we look to ways to support them. And then, of course, is the healthcare providers. So those who are actually interacting with children with palliative care needs. We are governed by a wonderful board of directors led by the amazing Dr. Michelle Mayring. That's a picture. There's Tracy and I in the top left-hand corner, and the rest of the people are our board of directors. And they, between them, have an enormous wealth of experience and expertise in the field. So just as Joan spoke about the evolving journey, and I think it's a really good theme for this webinar, is that you can start small and it will evolve. If you are looking to, we can't work with children, we don't know what we're doing, just remember that Sunflower started small and PATCH did as well. In fact, when Joan was working for HPCA, she was the pediatric lead for HPCA, and she actually helped very much what she spoke about happening at Sunflower House. She helped adult hospices around the country to develop their own children's program. It was often daycare for parents who were very sick, but there were also, we spoke about infected and affected children at that time. And she put together a group of people, and they actually were the core of PATCHSA. It was Michelle, it was Joan, it was myself, and there's probably people on this webinar who were part of that subcommittee. And we dubbed it PESCO, which was Pediatric Subcommittee. And this led to us thinking we need to have a national network, and very much led by Michelle and Joan, is we came up with, Joan and I were involved in the International Children's Palliative Care Network, so we thought we need to have a South African Children's Palliative Care Network. And so in 2012, it became formalized as a voluntary organization. And then in 2013, we met with, we fundraised for a bit of money, and we met with an advertising agency who pushed us to come up with a name that was more catchy and something that, and also helped us with our branding and our marketing. So in 2013, again, with this very small group of founding members, we launched PATCHSA South Africa on the 18th of September at a combined HPCA and APA conference in Johannesburg. And then we muddled along for a number of years, all of us doing the best that we could to develop PATCHSA. We were able to have a wonderful information officer, but funding was difficult. Getting people to devote time to PATCHSA was difficult because we all had our other jobs, but Michelle was absolutely determined, and we carried on until in 2017, we were very fortunate to get a very good funding amount from the Discovery Fund. And those of you who are South African will know that the Discovery is a very large insurance and financial institution in South Africa. The money that we got from this fund was actually to develop training and develop education to help, it was for 4 provinces to roll out an education and training program in 4 provinces. But first of all, to develop a book in association with Better Care, and then to use this book as a training guide. And so that was when PATCHSA got the money to hire Tracy, and everything was going fine. The book was being written and about to be published. And in fact, Tracy and I had started working a little bit for PATCHSA, and Tracy and I actually went and piloted our training project down in the Eastern Cape. And then in 2020, we all know what happened. We were hit by a pandemic. And so all our plans to roll out the training had to be stopped and put on hold. And Tracy and I and the committee we were headed by a steering committee at that time. We put our heads together and we said, well, we have this funding, we have this book, we have this wonderful training. How do we get it out there when we aren't even allowed to speak to our neighbors, basically? And that is where we came up with the idea of let's create an online learning platform. And so out of the ashes of the pandemic, Patch Academy was born. And Tracy and I went through a rather exciting but also torturous journey, learning about how do we take what we had in our book and what we knew about children's palliative care and turn it into an exciting online learning platform that actually was going to be available not just to the 4 provinces that we originally had the funding for, but this could be rolled out to the whole of South Africa and indeed to anybody else in the world who would like to access our courses. And so, as you can see, it's been a windy journey, but we've evolved from a small group of really determined people into the organization we are today, and the future really looks exciting for us. Just in case you're wondering, we are a membership organization. So if you do join as a member, and it's open to all members of the multidisciplinary team, some of the benefits of membership: you're part of decision-making at AGMs, you participate in election of board members, we offer discounts. There's a discount on membership of PALPRAC, which is the professional organization of palliative care practitioners. And I think one of the biggest benefits of joining PATCHSA is that you are invited to be part of our medical WhatsApp support group. And this is a very active support group. There's often people asking questions, doctors, asking about dosages, medications, asking for help, networking. Do you know of anyone who can provide support in this part of the country? So it really is a great benefit of being a member. And our fees are not really high. It's $350 for doctors, $250 for nurses and allied providers, and it's free to family members. So what resources and support can PATCH offer you? Well, we're not quite hopefully as intrusive as this gorgeous puppy on the keyboard, but we really are just a keyboard, a few taps on your keyboard away. Apart from membership and the medical support group I've spoken about, we respond to inquiries from the public, inquiries from the media. Joan was recently on television where she spoke about how to support the bereaving families from that terrible tavern shooting in East London. We often have parents writing to us and saying, I've lost a child, or I have a very sick child, and we are able to put them in touch with services. As you saw, they're not many, but Michelle over the years has trained a number of doctors as well around the country, and we can often find someone to help wherever this parent happens to be. We have an up-to-date website. I'm going to look at some of the resources on our website, so I won't go through all of this, and I will just move on to the next one. Here is our website. It's kept up to date. We have events, we have news, we have information for families, we have resources for families, we have resources for healthcare workers, and of course people can contact us. What will you find? Our vision, mission, history, the normal things for families. We have a map of services, so they can go onto the maps and they can see who is the closest service to them, and then the resources that we have for them, downloadable, all free. And then our textbooks are for the healthcare providers. We have links to textbooks. We have pain and symptom management resources. We have care and support resources, end-of-life care, planning resources, and we have our formulary. And this is an example. This is just one example of a number of PATCH resources that we have developed. This is, it's a color tool for assessing and locating pain in children. It's based on the Eland color tool, so those of you who've used that will know it. But we've developed one that is gender non-specific and is race non-specific. And this, you can go onto our website and you can download and print this out completely for free. So that's just an example of what we have that's relevant to a South African and a sub-Saharan African community. Our formulary is on there if you want to look at what drugs are available. It's also based on the UK, the Rainbow Guidelines, but it's only has medications that are available in South Africa, and then it gives you guidance on the age of the child, how much dosages, etc. So that can be found on our website. This is the book that Tracy led in the development of this book and what the funding from Discovery was for. This was published in 2020. It was written by a multidisciplinary team from PATCHSA. And again, it's a book that is relevant to the South African and sub-Saharan African continent. So it's not Eurocentric. And it's published in collaboration with Better Care. And they have a website, and it can actually be read completely free online, but you can't download it. So if you, and it's a useful book, and it's helpful because it has case studies, and then it has a quiz at the end, and it's actually used often for group learning in hospitals, clinics, etc. So if you just go to the Better Care website, you will find that. What else do we provide? We have monthly newsletters. We're on social media. We haven't quite managed to get onto TikTok yet, but all the other ones, you'll find us there. And we'd love you all to follow us on those, and so to keep up to date with what we do. We also provide person-to-person training. Now that COVID restrictions have been lifted in the country, it's going to be a lot easier to do this. In fact, Tracy has just been invited to do some in her part of the world. And this was our pilot for our first Better Care training that Tracy and I did. And I think the lockdown restrictions were announced while we were there in East London. So we can do person to person. It's not just online that we do. And then just a little bit about PATCHSA Academy. This is, as I told you, this was the phoenix that arose from the ashes of COVID. We started off with just 2 courses. It now has 10 courses that are up and running. We have 2 that are free. The others are very small, relatively low cost for you to do. They're very interactive courses. They've got lots of quizzes. They've got local case studies. And the best thing is that all of our courses, every one of them has been accredited with CPD points from the CMSA, both ethics and general points. And some of our courses have CPD points for healthcare professionals, social workers, and spiritual counselors. So please do go and have a look at that. Just that is the website, and just a little bit about them. We really wanted to make these not Eurocentric. We wanted to make them relevant to an African cohort, and we needed what we thought was lovely about this, as opposed to face-to-face training, is that people don't need to take blocks of time off, because these are online courses that can be done in your own time. So there's nobody, it's not, you don't have to join a webinar or anything like that. You just go on, you start the course, when you've had enough, you can pick it up another time, another day. It's accessible because in South Africa anyway, 95% of adults own a phone, so it is smartphone friendly, and so it's accessible to most people working in professions in South Africa, and particularly in the healthcare field. They're only in English. We did talk about translations, but we felt that English is at least the first or second language of most people in South Africa, and just to make life less complicated, they are only offered in English. The level that we've aimed at is a generalist level, for anybody who would possibly be a member of the multidisciplinary team on a palliative care, children's palliative care team. The structure of our courses, if you go back and have a look at the courses that we have, they're all actually based on the chapters that you will find in our Better Care book, except for the introduction one. So there's a chapter on communication, there's a chapter on pain, there's a chapter on cultural competency and spiritual care. So that's how we have actually structured the Better Care courses. And we really hope, and we have found them to be effective in changing attitudes and impacting practice. This was very important to Tracy and I, is to make the courses interactive. We really didn't want talking heads, and we really didn't want just flipping through a PowerPoint, because we could all do that if we just were given a PowerPoint. So we've really tried hard to make the courses engaging. They've got videos, they've got local case studies with questions. We've got lots of links to outside sources, to up-to-date research, to websites, downloadable resources. We've used voice files from healthcare providers. Then we've got little activities where the student drags missing words, complete sentences, or does true or false quizzes. So there's a lot of things to keep people involved. And I just love this quote that somebody sent in one of the surveys. They said the course can get a few pop-up notices to remind us to take a break. Otherwise, you can sit all day engaging till the point of exhaustion, which I actually thought was a compliment. Immediately after doing the course, just before you do an exam, there is a survey. And so this is the survey that I took the results a couple of weeks ago for this. And then we sent out a second survey a couple of weeks, or up to 2-3 months afterwards. And the blue, everything was rated on a scale of 1 to 5, with 5 being excellent, 1 being no good and poor. And you can see people's opinion of the course, the number of 5s and 4s that we got, how interactive the course was, whether the course met their needs. And in the longer term survey, we asked if it had improved their understanding of children's palliative care. And again, you can see that most responses were a 5. Whether it improved their practice, and this was exciting, is that these courses actually have made a difference in practice. And then the last question is whether they would do another. There were a lot more questions, but these are just the ones that I'd like to show you the results for. So far we've had 956 registrations and 458 courses have been completed, which means it's over a 50% completion rate. So what are the next steps for PATCHSA? As I said, it's really been an exciting last couple of years. Based on what we had done with the money we got from Discovery, they actually gave us another 3 years of funding. Our introduction course has now been made compulsory learning for 2 of the top South African medical schools at UKZN and UCT. We are soon going to have 62 healthcare providers at Red Cross Children's Hospital doing our courses. Our second book on perinatal and neonatal palliative care is just about to be published. It will be in the next couple of weeks. And then we will have an online course that will be based on that by December. And then next year, we're very excited about this. Tracy, Michelle and I have had lots of planning to do. We're going to offer a 6-month short course, which we really hope we'll be seeking accreditation for this through UCT. And it will be using our online courses with some webinars, some assignments, and a practical placement. So it'll be very much a blended learning course, and it will have a final exam. And this is very exciting, and you're just really getting a sneak preview of our logo. Next year, PATCHSA is going to be collaborating with PALPRAC and HPCA to bring a wonderful conference from the 26th to the 29th of April in Cape Town. So please save those dates. You don't want to miss this conference. And that's it. If you want to get hold of me, I'm just at you saw that picture with the puppy, I'm just at the end of the keyboard, info@patchsa.org.
Sue, thank you so much for that really wonderful overview of the great work and the evolving journey of PATCHSA. I like your idea that that's a theme of this webinar. It's been very wonderful to hear from all of you. We're going to move into a bit of discussion now. Sue, if you could stop sharing your screen. And we want to invite participants. You're welcome to raise your hand and we'll call on you to actually engage and ask questions, or you can feel free to put questions in the chat as well, and we'll handle those. Sue and Tracy, if you want to come on video and we can direct questions to you. So again, we invite questions from all of you, and we'll just moderate a bit of a discussion here. And I'd like to just kick it off, Sue. You said something small on this, but I think for those participants today who are not from South Africa, it sounds like the Patch Academy resources are valuable beyond South Africa. Can you speak a little bit to that, and maybe participants you've had from other countries take the courses?
Yes, absolutely, Lacey. Thank you for bringing that up. We have definitely had people from outside of South Africa do our courses, and in fact, we've had wonderful responses for them. Because at the end of the day, those of you who know Dr. Justin Amory, he always said children are children, and children's palliative care, is the same no matter where you go in the world. The only thing that changes is the resources you have and how you make use of them. And I think Joan's presentation just spoke to that, is you look around you and you say, okay, what have I got? What is around me? How can I use it? And so the principles are the same. We just wanted to present something that wasn't as Eurocentric as most of children's palliative care information is, but it's definitely applicable across the world, and particularly in low and middle income countries.
Great. Cindy, please go ahead.
Thank you, everyone, for the wonderful information that you shared today. There was so much here and so many takeaways that I was wondering if each of you could just take a moment to boil down one thing that you think that each of us could do to advance CPC. Just something that we all could do in our offices and our daily work to advance this great thing that you're doing here.
Who's going to go first?
Would you like me to go first? I don't know about officers, but I think those who are working in mainly adults programs is to recognize we never, as an adult program, don't work with children. And when we work with children, we work with adults. And to see children as part of this whole picture of palliative care. And instead of saying, well, I only work with adults, I only work with children, it isn't like that at all. It is, if I'm working with a child, I'm working with the adults who are linked to that child. It might be parents, it might be an aunt, it might be the care workers at the hospice. But working with children is really part of the big picture of palliative care. And if we see it as that, then children's palliative care practitioners will learn about adult palliative care, and adult palliative care practitioners will learn about children's palliative care.
Yeah, I'd just like to add to that as well, is that there's such a fear. I think the words hospice and palliative care in the general community, it's no matter how well you know someone. I had a neighbor and she knows I work in palliative care and I talk about it all the time. And when her husband was dying of cancer, and I suggested that she call in the local hospice, she's like, oh no, I'm not ready for that yet. And you just, I think if we can somehow just, by talking about it and explaining that palliative care is appropriate from the time of diagnosis, and it's about quality of life, and if we can just make sure that people understand that with children particularly, if they're accessing palliative care, it doesn't mean they're going to die soon. They, as Tracy mentioned, they could live for many years. And so I think it's just, how do we bust those myths that are out there? And the only way is information. Keep talking.
I think mine was the same. I was going to just say, just to know that children's palliative care needs to be family and patient-centered, the child being the center of care, but as importantly, that family that support and the extended family that support that child are in need. And we have to be involved with all of them and get to know them. And then other thing is just the exciting part for me always is just the diversity of the needs of a child, is to take those into consideration, that they are real little people and they've got huge needs as big as ours. And I think one of mine, I think that's why I'm in education, is that need for that education and learning and how we thrive as human beings to learn and play. And that needs to be so about learning the child's cognitive development, how they communicate at different levels. I think if you can just start reading about that, you don't have to know it all, but just to understand how they communicate, how they understand their little lives and those people around them. Children are egocentric. We need to understand them fully.
And of course, you can all do our intro course. It's free. Go to the Patch Academy and do the course. It's fun and it's free.
Yeah. And let's not forget to wear a hat for hats done for children's palliative care. That is something that everybody can do. It doesn't matter if you're in an office, you're going to the shops, you work in a hospital. It's a great way of raising awareness, is to wear a hats on for children's palliative care and to promote it. It is a fun thing that every person in the community can do.
It's on the 14th of October this year.
Thank you for that reminder, Joan. Last year I wore actually both of my sons played ice hockey here in the US, and I wore an ice hockey helmet for that day last year. So you may see that photo out there on social media somewhere. I think we shared it as Global Partners in Care. But it is fun, and we had a number of people at our offices participating in that as well. So thank you for that reminder. We really appreciate it. And thank you too for, the reminders that you've given us about education and talking and sharing knowledge about this. I think one of the things that, we all have in common with this is we were all children once. I know I'm kind of a far way away from having been a child, but I think if we go back and remember, what it was to be a child and sometimes not feel like we were being heard, or that people were asking us questions about what we felt and what we were experiencing, and helping us navigate the difficult parts of our lives. I think, what you've brought to this discussion today about that is so important, that putting the child at the center of this along with their family and being part of that journey as a respectful, understanding partner is so important. And thank you for reminding us of all of that. So, we greatly appreciate what you've shared with us today. For those who are Global Partners in Care partners, I would like to note that GPIC and PATCHSA are partnering to offer an opportunity for palliative care organizations, particularly those who focus on adult palliative care at this point, to deepen their learning in CPC and to better meet the needs in your communities. So we are going to work with them to do a consultation to develop relevant training and support programs that are tailored to the needs of your organization. You will receive an email from Global Partners in Care this week that includes instructions on how to apply, as well as an application. So please feel free to reach out to Lacey or I in advance of getting that application if you have any questions. But we look forward to this partnership and hope, again, that we can help build capacity in this area too.
Cindy, thank you.
I see there's a question that Lydia has posed, and I just wondered if Michelle, I know Michelle is on the webinar, if she wouldn't like to talk to her vision of the future, because I know she has an amazing vision of the future of CPC in South Africa.
That's great, Sue. Michelle, we'll turn it over to you, and I think this is a really perfect way to end the discussion today. If you could share your vision. This is a question from the chat, your vision for the future of children's palliative care.
Oh, thank you very much, Lacey. I must say, Joan and Sue and Tracy, it was amazing to actually see the history and to appreciate how far we've become. I think sometimes we don't realize it until we turn around and look at the road. Yeah, and I think to me, one of the things that I've been thinking about a lot of the time is once you've also, traveled a road, you can really help others travel that road as well. And I do think that South Africa is one of the leading countries in Africa when it comes to children's palliative care. And there's so much more that could be done for the rest of the continent. And I think, I know this might sound like a bit of an arrogant thing to say, but I do think that we actually could lead on a lot of the research because we have the numbers of children that they don't have in high income countries in terms of, especially, drug-related research and programs. So yeah, our very sort of ambitious idea for the future is, and thanks once again to Joan and her many connections, we are hoping to build a a pediatric palliative care center of excellence to be based in Cape Town that will house a mixture of clinical services as well as training and research space. And we're hoping that PATCH South Africa will be in our training space, so that not only will we be able to continue to deliver online training, but we're also planning to have a simulation lab and small little lecture halls so we can run more face-to-face training. And also, very importantly, I really do think, and I think most people on this call today will agree, and I think Joan's presentation really spoke to that, that the best teachers of palliative care are the patients and the families themselves. And the best school to learn from is not UCT, it's the School of Life. And one of the unique ideas behind the center is to actually be providing clinical services at the same time. So we're planning to run a 24-bed children's hospice, and we're hoping that people will be able to come and do clinical placements at the hospice and work with us, work with a local team to look after children at various stages of their disease. So we'll have an inpatient unit, and also going to be having an outpatient multidisciplinary clinic as well. And then, of course, very importantly, the research component. And, you know, like with training, I do also believe that the best research is also done with patients. So, you know, there's a lot of operational research that one can be done. We're actually, you know, picking up so many useful tips with patients as we work with them. And very few of these learnings are actually written up, you know. I think we've all been doing this for a long time and we've been so busy doing it that we haven't really had enough time to write things up. So, you know, bereavement support groups or, you know, children's counseling sessions, all of these could actually be utilized to really help others to kind of learn what are the best practices and also really help garner a lot more evidence base for pediatric palliative care. I do think it's very much a growing field internationally, but we really do need to get a lot more evidence-based. There's a lot of stuff that we do, which is sort of anecdotal. We've done it for many years. There are a lot of drugs that we use that are off license, which can be quite scary sometimes. And I really do think that we need to actually start collecting and publishing the evidence. And in that way, I think we'll also basically also really establish a better positioning for pediatric palliative care as a subspecialty within pediatrics. Yeah, so that in a short nutshell is our vision for the future.
Thank you so much for that. I don't think anyone can accuse you of thinking too small.
Yeah, they complain sometimes of thinking too big, but
you are a visionary, and it's achievable, I believe, with people like you at the lead. Joan, Tracy, Sue, all of you are visionaries and champions for children's palliative care, and we thank you so much for your time today and for all of your work with Patch Academy, Sunflower Children's Hospice, and everyone to promote children's palliative care. And Joan, I want to give you that last word. I think it's important. I see you've just posted this. Please go ahead. Oh, you're muted there, Joan.
Unmute. Good.
Unmute again. I'm unmuted. Okay, I don't know if it was my quote from Sister Frances Dominica, who said, "They, the children, are the teachers, we are the pupils. It is a masterclass." But also my vision for the future is to see children's palliative care as part of the undergraduate training of every single person dealing with children. And that includes teachers, music therapists, everyone who is going to work with children, so that it becomes an absolutely normal part of health care, that it isn't something separate that the NGO sector is having to talk about. It is something that every single clinical person, every teacher, everyone working with a child will see it as an essential part of their practice, because we all need to learn bereavement skills, we need to learn communication skills. We don't have to be clinicians to do that.
That's wonderful. Thank you, Joan. And there's agreement in the chat with that. Well, we've reached our time. Cindy, did you want to say a closing word?
Just thank you again to everyone for being part of this today. I know I'm walking away with a whole new appreciation, both of the work and what is still left to be done, which is always a lot in the palliative care world. But thank you to everyone here for making this such a great webinar, and have a wonderful, wonderful journey.
Thank you all.
Thank you so much.
Thank you so much.
Thank you.
Thanks so much again.
Great.